Hi, welcome everyone to the series of Fun of Medicine. Okay, so right now what we're gonna talk about is that renal pathology. The first topic that we're gonna talk about is that nephrotic. So nephrotic, to see signs of nephrotic, basically is that there's a criteria for nephrotic. You are losing protein loss more than 3.5 milligram. Okay, read me. And you will have edema. Why? Because when you lose a protein inside the blood vessel, the fluid will tend to leak out. Okay? And so there's different causes for nephrotic. What are the causes for nephrotic?
Vascular?
Yeah?
Damage. Inflammation.
So there's different. So patient present with nephrotic, there is different. Number one is that focal segmental glomerulonephritis, and there's the second cause is called minimal change disease, and there is the third one is that membranous glomerulonephritis. The fourth cause is that amyloidosis. The fifth one is diabetic glomerulonephritis. Do you see the screen? Okay, so now we're gonna talk about, I'm gonna give you a case with all these features. So nephrotic syndrome is that urinalysis, you will find a protein 4+. That's how the case present. Patient present with fatigue, tiredness, leg edema. This is the patient, how the patient present. Puffy face because of the swelling, and they may have an increased risk of thrombosis. They may have renal thrombosis. Those are the features. An increased cholesterol, hyperlipidemia. Okay, those are the features of nephrotic: hypercoagulability, hyperlipidemia, puffy face. Those are the main things. Okay. Plus, if I tell you any of these other causes, now I'm going to give you the subdivision of the causes. What if I tell you on electron microscopy I found effacement of podocyte photoprocesses, and immunofluorescent we found effacement. I'll show you what is it. Podocyte effacement, podocyte photoprocesses effacement on electron microscopy. Look at this. So you see, this is how the normal. You see this picture? This is the normal. There is podocyte photoprocesses. In pathology, there is no photoprocesses. So these food processes increase absorption. While if there is no photoprocess, this means low absorption. So that's why you will find effacement. Okay?
Yeah, but what's effacement?
That's effacement mean lack of podocyte photoprocesses, mean lacking. Okay, that's what effacement means. On immunofluorescent, you will find focal deposit of immunoglobulin M, IgM, C3, C1. And on light microscopy, you will find segmental sclerosis and hyalinosis. Okay, and present with African American, Hispanic, and there is two different causes. There is a primary causes. What is the primary causes of? The primary causes either idiopathic or secondary causes. Secondary causes is that no, this condition that I'm asking you. What is this disease? What is this disease that I'm giving you? I'm listing you the criteria and you can tell me the disease. So, and associated with HIV or sickle cell anemia or heroin use or obesity or interferon treatment or chronic kidney disease. What is this disease?
Minimal.
Huh?
It's minimal.
So minimal change disease in children happen? This patient is adult.
It's a focal.
Excellent, good job. So this one is the focal segmental glomerulonephritis. This one is this one. Okay. So this one, it's
So if it's not a kid,
focal segmental.
it's an African American. It's focal.
Yeah, excellent, good job. Okay.
Because
So this is,
you can have diabetic with diabetic nephropathy.
yeah. But
what difference?
But you're not gonna have focal. We're gonna come to it. We're not gonna have focal deposit in the diabetic nephropathy. Different. The presentation is different. Okay.
Focal deposit of what?
Focal deposit, focal sclerosis, and hyalinosis. I'll show you.
Sclerosis.
Focal sclerosis. I'll show you how the picture of it. It's usually cool with pictures of the time per minute. I like seeing pictures. So you see? Do you see this? Focal sclerosis.
Yeah, you kind of need to zoom in because they all look alike.
See? You see focal sclerosis here. Sclerosed segment. This is associated with focal segmental glomerulonephritis. Okay? Case 2. Now I'm going to give you another case and I want you to know what's the diagnosis. When I finish, you tell me the diagnosis. Okay? So child present with edema on the leg. Oh, just hold on a second. Let me give you the light microscopy finding. Biopsy normal. On the immunofluorescent
Food process.
negative, nothing. On electron microscopy you will find effacement. Okay, there's two causes. There's a primary causes, which is idiopathic. How do you treat the primary causes? You treat the primary causes with a steroid. Or secondary causes associated with infection or lymphoma or immunodeficiency. Okay, what do we call this disease? And you will find lipid in the proximal convoluted tubule. Excellent, good job. How do you know? That's fantastic. So this is one. It's called minimal change disease. Okay, this one is minimal change disease. So we finished focal segmental glomerular. Oh, what happened? Yeah. So this one we finished focal segmental glomerulonephritis, and then this one minimal change disease. Okay, I'll give you the third case. You ready?
Can I have a question? Or you let me know when I can ask them.
Okay, now we're gonna come to the third case. Okay, so the third case, the causes, there's two different causes. There's either primary or secondary. The primary, it could be idiopathic and mostly happen in Caucasian. Secondary, associated with either antibodies to phospholipase A2 or non-steroidal anti-inflammatory drug like ibuprofen or penicillamine, or infection. Like what type of infection? Associated like hepatitis B virus, hepatitis C virus, SLE, solid tumor, okay, and could present to chronic renal failure. When we do renal biopsy, this is what we're gonna find. On light microscopy, we're gonna have diffuse capillary thickening. And glomerular basement membrane thickening. Okay. On immunofluorescent, we will have granular interstitial deposit, granular deposit. On electron microscopy, there is very fancy names called spikes and domes appearance. What disease is that?
Membranous.
Good job. How do you know that? That's
Spikes.
fantastic. Okay, good job. This is membranous Nephropathy. And this what, let's see the spikes and dome appearance. I like this spikes and dome appearance. Spikes and dome appearance, okay? You see, it's like this. Do you see this one? This spike and dome appearance. This one's called Membranous Nephropathy. Now we're gonna come to the third case. So a patient present with history, 40-year-old female, long history of rheumatoid arthritis for 10 years. Don't take medications. Okay, present with all signs of nephrotic syndrome. We did renal biopsy because she has nephrotic syndrome. So what we found on light microscopy with Congo red stain, we found appearance called apple green birefringin. Let's see how does that look like.
This is a hump.
Green birefringin, Congo red stain. You see, it looks like this. See the green apple.
Is there any other way to describe? Because I don't have that in my notes.
This one, there is another this one that the most common, and this one, this disease also associated not with rheumatoid arthritis, associated. That's the main thing that I know. Maybe some other ways. I'll look this up and I'll let you know. There's multiple myeloma associated with the tuberculosis and rheumatoid arthritis, like this patient that we have. What do we call this disease?
It's diabetic.
It's amyloidosis.
Oh my god.
Okay.
You know, I never studied amyloidosis, that's why I never get it.
Okay. Okay, that's
I don't have it in my notes.
Oh, okay, no problem. So now we're gonna talk about a different one. Very interesting, exciting. There's a. Okay, now we're gonna talk about 60-year-old male. Okay, have history of diabetes for 20 years. Difficulty vision, difficulty seeing at night. Vision at night. This is number thing. Other thing is that he have pins tingling sensation in legs. Okay, his blood sugar is 300 uncontrolled. He's on metformin and insulin. We did the biopsy. Are you with me? We did the biopsy of the kidney. What we found glomerular basement membrane thickening and eosinophil. What do we call it? Kimley-Steele
Diabetic.
Steele-Wilson nodules. Let's see how does Kimley-Steele-Wilson nodules appear on picture. So let's Google that. Kimley-Steele-Wilson nodules. Thank you. So those are the Kimley-Steele-Wilson nodules. Let's see how does those look on. You see, those are the Kimley-Steele-Wilson nodules. You see, it's basically thickening of the glomerular basement membrane. You see, thickening of glomerular basement membrane and eosinophils surrounded by. So that's what what do we call these conditions?
Diabetic glomerulosclerosis.
Diabetic glomerulonephritis.
Nephritis.
Yeah, same, it doesn't matter. Okay, so there is very important about the pathophysiology of this diabetic, because it's very important and high yield, so we're gonna know the path. So first, the glucose start to precipitate in the glomerular basement membrane. The first sign is gonna happen is that increased permeability, increased hyperpermeability. After that, what's gonna happen will increase the GFR. GFR because of increased permeability. Why? Because there is damages to the glomerular basement membrane. After that, you will have where we have something what's called mesangial expansion. Okay. After that, start leaking of protein. So this happened over a lot of years. Okay. That concludes summary of nephrotic. Okay. So just to review in a nutshell, nephrotic present with.
Question about the diabetic.
Okay. What is it? So basically this summary, okay, of the nephrotic. If they gave us, so this the general there is general symptoms and there is specific symptoms. General symptoms is that urine protein, urinalysis protein 4+, fatigue, tired, leg edema, puffy face, renal thrombosis, hyperlipidemia. The specific symptoms, the specific association. Patient present HIV, sickle cell, heroin, obesity, interferon, chronic kidney disease, segmental sclerosis, African American, Hispanic. What's that?
Focal.
Excellent. Focal segmental glomerulonephritis. Patient present the specific symptoms, that child or have history of lymphoma, immune deficiency, infection, and there is effacement of photoprocesses on the electron microscopy. What is that? Minimal change disease.
Minimal. Did you say that it was a kid?
Yeah. So either patient is Caucasian, antibodies to phospholipase A2, non-steroidal anti-inflammatory drug, penicillamine, hepatitis B virus, hepatitis C virus, SLE, solid tumor, chronic renal failure. What is that?
Minimal.
Huh?
Minimal?
No. Antibodies to phospholipase A2, associated with hepatitis B virus, hepatitis C, SLE, solid tumor, chronic renal disease. There is, on light microscopy, you'll find diffuse capillary thickening and GBM thickening. Immunofluorescent granular deposit. What is that? And you'll find spike and dome appearance.
Don't tell me. It's not membranous?
It's membranous. Okay. 40-year-old female with 40 years history. Amyloidosis. 6-year-old with 20-year history.
Oh wait, but for
amyloidosis. Okay, so those are the summary of nephrotic syndrome. Okay. So right now we're gonna talk about nephritic. Okay, so the key features of nephritic, that's a giveaway clues. Those are the key features. Okay, just so there's, when you see RBC cast, this is nephritic 100%, and when you see hematuria, this is nephritic for sure, because it's basically inflammation of the kidney, and the protein level is at less than 3.5 milligram. Okay, those basically the most important thing. And there is different types, different differential of diagnosis of nephritic. Nephrotic syndrome is either could be post-streptococcus glomerulonephritis, or it could be rapidly progressive glomerulonephritis, or it could be diffuse proliferative glomerulonephritis, or it could be the fourth one, Iga nephropathy, or it could be the Alpert Syndrome, or it could be the Membranous proliferative glomerulonephritis. Okay, so that's what it is. Basically, this is nephritic, rather inflammation, rather than damage to the basement membrane. While nephrotic is much more damage to the basement membrane than nephritic. Okay, so now we'll talk about post-streptococcus glomerulonephritis. So how does it present? Present when you have a 20-year-old child had a history of sore throat 2 weeks ago, and now present with cola-colored urine. Let me show you how does that color-colored urine gonna appear. This is a giveaway clue for Streptococcus glomerulonephritis. Every time I see color-colored urine, it's like this.
Which is brown.
You see, it's like this. Let me see, why is it like this?
So, can you say something?
Okay, so this is the okay, so color-colored urine, and this is the main thing. This is the present with color-colored urine, and you'll have periorbital edema. This is the way they present. Okay, and so when you did the lab, what you found decreased complement level. In the blood, and you'll find increased anti-DNase B titer. This increased, and you will find hypertension in the child. That's the presentation that's gonna happen. Then, if you want to do renal biopsy, usually the doctors figure it out without biopsy. But if some doctors need to do renal biopsy, you will find in light microscopy, you will find hypercellular. On immunofluorescent, you will find starry sky appearance, or plus lumpy pumpy deposit. What does the lumpy pumpy deposit have? The lumpy pumpy have IgG, IgM, and C3. On electron microscopy, what are you gonna have? You're gonna have subepithelial immune complex humps. That's what you're gonna have. So let's see renal biopsy. Let's see the starry sky appearance. Starry sky appearance in kidney. You see, it's like this. Look how beautiful that is. It looks like this. This starry sky appearance. By the way,
like amyloidosis.
No, amyloidosis looks different. You see. See, amyloidosis is this different. So this Nephrotic Syndrome, starry sky appearance, and you will find lumpy pumpy deposit. Let's see the lumpy pumpy deposit. Pumpy deposit. You see, this one is the lumpy pumpy. See? Okay, so what do we call this disease? This is Streptococcus glomerulonephritis, okay? You got it?
Do you have immune?
Okay, now we're gonna talk about rapidly progressive glomerulonephritis. This is the serious condition. This one, the poor prognosis. If you wanna choose this one, this is very poor prognosis. So this one developed to renal failure in weeks. This one is the worst one that you can ever have, and this one is associated with serious conditions. It's called vasculitis. What type of vasculitis? Those are, I want you to remember that. Wagner granulomatosis and polyangiitis and microscopic polyangiitis. That's what they call it. Wagner granulomatosis and microscopic polyangiitis. Basically, these are inflammations of the vessel, of the whole vascular system. So if I show you what's Wagner,
I know those conditions.
You know, present with sinusitis, sinus infection.
Yeah,
See?
you lose the nose.
Yeah, so this is basically Wagner.
It's horrible.
It's a systemic disease. This damages the vessel, damages the kidneys, and damages a bunch of other organs. So that's why it's associated with that. And some associated with the glomerular basement membrane. Goodpasture syndrome, Goodpasture syndrome, GPS. Okay, which is type 2 hypersensitivity reaction. In this case of GPS, an immunofluorescent will be linear deposit. Okay, so what do you find on light microscope if you want to do renal biopsy? Because this is serious. What are you gonna find in renal biopsy? Crescentic glomerulonephritis, crescentic, moon-shaped. What are you gonna have in this? In this, fibrin and protein C3b. Okay, or you may have also glomerular and parietal cells, monocytes, and macrophages. Okay, you got it?
Yeah.
And you will have hematuria also, excessive hematuria, hemoptysis. That's something serious, very serious. And there is something very important I want you to remember, is that in labs, you're gonna have type of antibodies. What antibodies? Do you know? It's called PR3 ANCA, anti-neutrophilic cytoplasmic antibody, and C ANCA. And other proteins called myeloperoxidase, ANCA, or perineutrophilic anti-neutrophilic cytoplasmic antibodies. Okay, those are the antibodies that you're going to be associated with that. How do you treat it? This is something serious because you have a lot of antibodies attacking the kidneys. So the way you do it, you do plasmapheresis. Okay, so this is rapidly progressive glomerulonephritis. There's this one, diffuse proliferative glomerulonephritis. The most important, I'm just explaining the most high yield and the important stuff that every medical student needs to know about each disease. So, diffuse proliferative glomerulonephritis, what I want you to know is that associated with systemic lupus erythematosus. That's the main thing. The other thing is that when you do renal biopsy, you will find on light microscopy, do you know what the finding? You'll find wire looping of capillaries. And on electron microscopy, you will find subendothelial IgG based immune complex C3 deposit, which is C3 immunocomplex. On immunofluorescent, you will find a granular deposit. Okay, so let's see wire looping of capillaries. Do you want to see how does that look like? Do you want to see how does it look like?
Yeah.
So let's see, it's like this. You see wire looping of capillaries, this one. It's like wires. This is a sign of this disease. Okay, that's all what you need to know about it for at this level. Now we're going to talk about Iga Nephropathy. Iga Nephropathy is sinus infection or any infection in the upper respiratory tract. Okay, upper respiratory tract infection, and within 1 week, that's the main difference between this and positive glomerulonephritis is the timing. That's the main thing. So associated in 1 week, and then they develop hematuria. That's the present, and usually it's a teenager or a child. Okay, this is one presentation. Another presentation that's gonna present, I'll tell you, like 13-year-old child present with rash on the butt, abdominal pain, and hematuria. What is this? This is typical condition. Is called Heno-Schulin purpura, which is manifestation of Heno-Schulin purpura is Iga nephropathy. Okay, in this case you will have acute gastroenteritis plus hematuria and RBC cast. Okay, this is difference. This is the sign or symptom. Don't confuse that with Berger disease. So there is something called This is very important. Berger disease, which is called thromboangiitis obliterans, which is totally different condition. And there is something called Berger disease. This one, Berger disease, is the same one, Iga Nephropathy. So don't confuse the both. This one is vasculitis, and this one is kidney glomerulonephritis. Okay, make sure you differentiate between those. And then when you do renal biopsy, sometimes for the basic days trial, they like to bring renal biopsy manifestation, just in case if you want to go pathology. Renal biopsy.
Use your fingers and your smoker.
Yeah, that's true. Yeah, auto amputation. So this renal biopsy, what do you have on light microscopy? You will have mesangial proliferation. On electron microscopy, you will have mesangial immune complex deposit. On immunofluorescent, you will have IgA-based immune complex deposit. Okay, so this is basically the IgA nephropathy. Now we're going to talk about Alpert syndrome. Whatever you need to know about Alpert syndrome, so this is the way you present. Let's say 8-year-old kid has difficulty hearing, can't see, can't pee, can't hear the buzzing bee. So he can't hear, can't see, can't pee. Okay, it's basically a defect in type 4 collagen. That's why you will have thin split in the glomerular basement membrane. And the electron microscopy, you will have fancy appearance called basket weave appearance. So this is if I just write Alpert syndrome, you will see this thin Alpert syndrome. You see it affect the ear. You see this is Alpert syndrome. It affect this condition, and you will see this thick and thin split. See, this is thick and thin split, abnormal split and laminated glomerular basement membrane. This abnormally thin glomerular basement membrane. Okay, this is the Alpert syndrome. Now we're gonna come to the last one, which is membranoproliferative glomerulonephritis. In membranoproliferative glomerulonephritis, there's two types. There's type 1 and there's type 2. Okay, this is important. So this is the way we know the difference. In type 1, you will have these subendothelial immune complex deposit. And on immunofluorescent, you will find something is called track appearance. Okay, on H and E stain, and associated with hepatitis B and hepatitis C, and could be idiopathic. Okay, so let's see track appearance. This looks something fancy. See this one, tram and track appearance. It looks like a tram and track, double glomerular basement membrane. Why? Because of the mesangial growth. So when the mesangial growth grow, it basically split the basement membrane. You see? Here there will be a split. That's what they call it, tram and track appearance in the glomerular basement membrane. Okay, so this is, what did you call this? This one is type 1. How about type 2? So type 2 is the only difference that you know this endothelial cell. So this endothelial cell, if the antibodies deposit below the so this is the endothelial cell. See, if the antibodies deposit below the endothelium, this we call a subendothelial deposit. If the antibodies deposit in the membrane, this we call intermembranous immune complex deposit. That's what we call type 2. So type 2 is intermembranous immune complex deposit. It's called dense deposit and associated with C3 nephritic factor. Which is the molecular protein that stabilizes C3 convertase. Okay, and you will have on labs, you will have decreased C3 level, like post-toxic glomerulonephritis. Okay, so that's basically membranous proliferative glomerulonephritis. Okay, so in a nutshell, summary of the nephritic. Okay, so I'm gonna ask a question really quick, and you tell me the answer. So, patient present with the sore throat 2 weeks ago and present with cola-colored urine. What's the diagnosis? Excellent, post-toxic glomerulonephritis. Patient present with very poor prognosis and associated with sinus destruction and generalized inflammation, and renal biopsy you find crescentic and associated with pianka. What's this?
Rapid pathology.
Excellent, rapidly progressive glomerulonephritis. Patient present with SLE and wire looping of capillaries. What do we call that?
IgA.
It's called diffuse proliferative glomerulonephritis. Patient present with a child who have abdominal pain and rash in his butt and hematuria. Iga Nephropathy. Good job. This is shown in purple. Patient can't see, can't pee, can't hear the buzzing pee. What is that?
Alpert something.
Alpert. Good job. Patient present with subendothelial immune complex deposit and trauma tract appearance, hepatitis B virus. What is that?
I don't know.
Membranous proliferative glomerulonephritis. Okay. So this concludes our discussion about nephritic and nephrotic syndrome. Thank you so much, and see you guys next lecture.